Products are shown for demonstration purposes only. The AHA does not endorse or recommend any specific manufacturer or product. In order to show skills clearly, the healthcare providers in this video do not always use recommended personal protective equipment, such as gloves. To help improve your assessment skills, the American Heart Association training series includes videos of actual children with medical problems. And of course, at no time was medical care delayed for the purpose of obtaining this video. All children received timely and appropriate medical care, and parents provided consent before recording. Patients display a wide spectrum of responses after successful CPR. After the return of spontaneous circulation, or ROSC, patients may become responsive with adequate spontaneous breathing and good hemodynamic function and systemic perfusion. Other children may remain comatose, apneic, and hemodynamically unstable. Many will require invasive monitoring for optimal management after resuscitation.
After ROSC, your immediate goals are to optimize oxygenation, ventilation, and perfusion, particularly to the brain. That's critical.
As you're addressing these goals, it's important to consider possible contributing factors. With these in mind, let's get back to our immediate goals. First, start with airway and breathing.
You want to make sure the airway is patent and confirm appropriate endotracheal tube placement. End-tidal carbon dioxide or capnography will tell you the tube is in the airway. A chest X-ray is used to evaluate the depth of ET tube insertion and rule out main stem bronchus intubation. When possible, titrate oxygen to maintain pulse oximetry saturation levels between 94 and 99%. Now, this ensures adequate oxygenation without the risk of providing excessive oxygen, which could lead to reperfusion brain injury. Optimize ventilation to maintain carbon dioxide levels appropriate for the patient's specific condition while limiting exposure to severe hypo or hypercapnia. Now, this can be evaluated indirectly by capnography or directly by a blood gas analysis. Obtain a blood gas when possible to correlate with end-tidal carbon dioxide levels. Once you've established a patent airway and optimized oxygenation and ventilation, assess and support the child's hemodynamic function and systemic perfusion by optimizing cardiac output.
Remember, cardiac output is the product of heart rate and stroke volume. Let's talk about heart rate first. Aim for a heart rate that is appropriate for age and clinical condition. Monitor for bradycardia and tachyarrhythmias and treat aggressively if they occur. Bradycardia can occur due to hypoxia, hyperthermia, or cardiac dysfunction. If bradycardia develops, first ensure adequate ventilation and oxygenation. And if bradycardia persists, follow the bradycardia algorithm. Now let's consider stroke volume, which is determined by preload, contractility, and afterload.
To increase cardiac preload or the stretch and filling of the ventricles, we administer fluid boluses. Children who've had a cardiac arrest often have poor myocardial function and may not tolerate fluid boluses of 20 milliliters per kilogram. That's why you should consider smaller fluid boluses over a longer period of time. To optimize preload in these patients, give 5 to 10 milliliters per kilogram over 10 to 20 minutes. It's also important to reassess the child after each fluid bolus. After you've addressed preload, remember that cardiac contractility may be impaired as well. Assess and correct for hypoglycemia, electrolyte imbalances, and hypocalcemia. If myocardial function remains poor, the use of inotropes such as epinephrine or inodilators such as milrinone may be useful. Hypertension may develop in the post-cardiac arrest period. This may be caused by agitation or seizures. Although hypertension can contribute to increased ventricular afterload and poor cardiac output after ROSC, immediate treatment is rarely needed. Be sure to avoid hypotension and treat it using fluids, vasopressors, or both. Your goal is to improve perfusion and achieve a systolic blood pressure greater than the 5th percentile for age.
Intra-arterial pressure monitoring may be needed to continuously monitor blood pressure and rapidly identify and monitor treatment of hypotension. Neurologic outcome is a fundamental concern after every cardiac arrest. In the immediate post-cardiac arrest setting, you must take the appropriate steps to optimize the child's neurologic outcome. Equally important is preventing secondary brain injury, which may be caused by hyperthermia, hypotension, hypoglycemia, or hypoxia. You should also treat conditions that increase the metabolic demand of the brain, such as hyperthermia or seizures.
Now, many children develop fever, which may be harmful, and for all these children, you should aggressively treat fever. However, mild hypothermia is common after pediatric cardiac arrest and should not be aggressively treated.
For comatose children resuscitated from out-of-hospital cardiac arrest, providers should maintain either 5 days of normal thermia, defined as 36 to 37.5 degrees Celsius, or 2 days of initial continuous hypothermia, defined as 32 to 34 degrees Celsius, followed by 3 days of normal thermia.
Seizures may be the result of hypoglycemia, electrolyte imbalances, or the underlying brain injury. Check bedside glucose and rapidly correct hypoglycemia. You'll want to recheck glucose levels routinely to ensure that you're adequately treating hypoglycemia. Finally, when necessary, transport the patient to the most appropriate level of care.
Attention to the details of post-ROSC oxygenation, ventilation, perfusion, and neurologic care are important. Addressing all of these factors will help your patient achieve the best possible outcome.